The next talk is Enhanced Surgical Recovery Program and Update by Dr. Vijaya Gottumukkala, who's the professor in the Department of Anesthesiology in the University of Texas. The question for your voting pad is, all are true in Enhanced Recovery Protocol except pre-op counseling, optimization of nutrition, standardization analgesic regimes, and late mobilization. Your time starts now. Over to you, sir.
Thank you. Good morning, everybody. I want to thank Dr. Balavenkat and all the organizers of Ganga Hospital for this kind invitation and organizing this fantastic meeting. In addition to the excellent scientific program, we had an excellent leadership summit last night, and also the off-site sessions which Dr. Balavenkat has organized. With regards to the question, I'm glad that most of you have answered correctly. So although the talk is Enhanced Surgical Recovery Program, in effect, what we are talking about is patient-centric, high-value perioperative care. So this is putting patient at the center of everything we do. But just before we get to the talk, for those of you who are not familiar with Houston, this is an overview shot of Houston. That's Houston downtown, which is just south of the airport. And this building complex is Texas Medical Center. And MD Anderson, which comprises all these buildings, is part of the whole Texas Medical Center. Texas Medical Center is the largest collection of medical institutions in the world. We employ about 100,000 people, annual budget of over $30 billion. And as I've said, MD Anderson is one of the institutions in Texas Medical Center, and I'm so honored and fortunate to be part of that great institution. MD Anderson is purely a cancer hospital, so every patient that comes to MD Anderson is either a current cancer patient or a cancer survivor coming for other procedures. So we don't do anything other than cancer. Our annual budget is about $4 billion. We have 39 operating rooms currently functioning. We have 6 in reserve should we have to open them up. We send anesthesia teams to 17 locations out of OR. Annually, we do about 49,000 anesthetics, out of which 20 anesthetics are within the OR and about 29 anesthetics outside the OR. We have a department of 100 faculty. So it's a large department and it's a large organization and enterprise. So when you talk about enhanced recovery or patient-centric high-value care, as I've said, it's putting the patient in the center. And everything we're going to do is to get the patient back on track. So the patient to be able to continue with their life or gainful employment or life's needs, whatever that may be. But this is not new. Professor Henrik Kælet from Denmark has been talking about this for about 30 years. And he used to call it fast-track surgery or stress-free surgery. And if you heard him talk, he's a very dynamic, engaging speaker. Although he's a surgeon by trade, he's an anesthesiologist by heart. All his lectures are mainly within anesthesia societies and circles, and he's an excellent human being as well. So although he's been talking about this for 30 years, it's only in the last 20 years or so it has been a main movement in Europe, and in the US, it's only been around 10 years. So if patient is the center of focus, why is it that it has taken us so long, and what is driving this movement? At least for the US, it's this: market drives everything. We are not sure how the Healthcare Act is going to change with the Trump administration, but for sure it's going to change. But the economics is going to force us from a volume-based payment structure to a value-based payment structure. So while it used to be fee-for-service earlier on, we are somewhere here right now, but I think we are going to go for global payments and capitation, which I think has already come up in Indian markets and certain segments of care. So this is what is driving it, especially in the US. But from the whole system's perspective, healthcare delivery in the US is very expensive. If we don't cut down our costs, we are not going to be able to sustain our programs. Right now, you can see about 2016, 17 here, major health programs already occupies the largest federal government's expenditure as a term percentage. And if we continue down this path, it's going to far overtake all other discretionary spending. So it's not only from the payer's perspective, but also from the government's perspective, it's becoming a major issue and movement. At the same time, patients are also looking at the cost of care. So this is a recent survey which was done, and when they asked patients what determines which institution or which providers they go to for care, over 50% of them said cost. So really, it's the market which is driving all these changes. So with that background, what I'm going to do over the next 20 minutes or so is to discuss functional disability in surgical patients, what happens after surgery if you're looking at functional capacity or functional activities, perioperative strategies to minimize that functional disability after surgery, and then I will highlight some of our own experiences over the last about 6-7 years. So it's interestingly just about 2010 when enhanced recovery was being discussed at many major institutions within the US, we at MD Anderson have started to look at basically the same principles but for a different set of reasons. It just so happened the time that all the ideas came together, and then we had to change our thinking a little bit, talk about enhanced surgical recovery, and see if these strategies or activities can in fact improve oncological outcomes for our patients with cancer. As we know, most, if not all of our patients come with some disability, that's why they're coming for surgical care, and incur some disability from what we do to them, right? So if you look at the functional capacity of the patients, immediately after surgery, day 0, day 1, there's a sharp decline in functional activity of the patient, and over a period of time, the patient gradually returns to their normal baseline. That's if they don't have any surgical complications. And what our goal is to minimize that decline immediately after surgery and see if we can get the patient back on track at a much earlier pace. So this is not a cookie-cutter approach. This is not one size fits all. Obviously, what we do depends on patient factors, their age, their preoperative functional capacity, their comorbidities, their disease state and stage. And based on the patient factors, then we design a surgical plan, whether it's an open approach or a minimal access approach, whether it's a radical resection or a palliative procedure. And once we have a plan based on the patient needs and the status, then the most important yet underestimated or unappreciated factor is patient engagement, activation, and empowerment. So we found that this really is one of the main foundations if you want to help the patient get back to baseline and help themselves with their recovery. With these foundational factors, the pillars of enhanced recovery are going to be opioid-sparing, multimodal analgesia strategies, minimize oxygen debt. By that, I mean giving the right amounts of fluids, maintaining your hemodynamic indices and parameters, and making sure the patient has adequate amount of blood, but for that physiology to provide that oxygen delivery. So whenever you talk about oxygen debt or fluids or blood or hemodynamic management, really the three of them come together. It's not physiologic sense to discussing each of them in isolation. And I'm not going to go into the details of opioid-sparing strategies or strategies to minimizing oxygen debt because I'll be covering these tomorrow in the talk titled Role of Anesthesiologist in Improving Long-Term Outcomes. One of the important post-operative components of enhanced recovery is standardized pathway-based post-operative care. Goal is early dreams which is drinking, eating, and ambulating. Most of our patients who have complex colorectal procedures and after liver resection have a regular diet the very next day. So this is becoming an important component of enhanced recovery. And then lastly, but very important, again, I'm going to elaborate on this tomorrow, is rapid rescue from postoperative or impending postoperative complications. So these all lay the foundations for enhanced recovery programs. So to sum up, it's not a technique, it's a philosophy of care. It's across the entire perioperative continuum, so you have to start this in the preoperative phase, continue in the intraoperative, postoperative, but also post-discharge phase. It's multidisciplinary. You cannot do this in isolation. You have to have the preoperative nurses, anesthesiologists, pharmacists, nutritionists, rehab folks, nurses on the floors, and the surgeons on board. So it's truly a team effort. And by doing all of this, our goal, as discussed, is to minimize symptom burden and complications, focus on the patient coming back to their baseline status, and reduce and minimize readmissions. So this is just, again, a slide which shows the interventions in each of the phases of surgical care, starting with the preoperative phase. Again, patient education and evaluation is very important, particularly in like India, where there's a lot of cultural taboo and expectations. So talking to the family, engaging them in their own care, and empowering them to help themselves is very important. Then intraoperative, we talked about everything we can do. We'll discuss more about this tomorrow. And in fact, in the postoperative phase, we have to build on and continue on the intraoperative interventions like the opioid sparing strategies. And then we have to follow the patients. If you want to really track your outcomes, you have to follow them. And this is a continuous PDCA cycle or an ongoing quality improvement project. So you really have to see if the interventions are working. If they're working, you want to build on them. If they're not working, you want to change and to see what can be improved. So what did we do at MD Anderson? Our enhanced recovery initiative really started with liver as our pilot program. We started this in about early 2013, and this led the way for everything that had come. Our traditional program was very strong. In fact, we have one of the best outcomes anywhere in the world, which is with regards to hepatic resections for either primary malignancies or metastatic liver resections, following mainly colorectals. So our standard care used to be a very heavy epidural-based analgesia regimen with volatiles and narcotics, and we already were not using that many surgical drains or limiting the use of nasogastric tubes. So already from a very good program, when we jumped to enhanced recovery, the main changes were patient education, engagement, and empowerment, and then we used to give or started giving them opioid-sparing adjuncts in the preoperative phase in the holding area. So every patient, if there are no contraindications, they get PO celecoxib, tramadol extended release, and pregabalin, all in oral formulation. Intraoperatively, we moved away from volatiles to a total intravenous anesthetic-based techniques, but again, that's not mandatory for any enhanced recovery program. You can do very well with a volatile-based technique. Over the last 2 to 3 years, as a practice, we are moving away from central neuraxial techniques like epidural catheters to more somatic blocks, to the 4-quadrant taps, and even more recently, within the last 3 or 4 months, we're, at least in my practice, we are mainly doing transmuscular quadratus lumborum blocks. For postoperative analgesia, we carry on the same. In the postoperative phase, the important change has been to cap the IV after patient takes about 600 mils of fluid orally and is able to sustain it. And most of our patients are able to take that amount of fluid by the same evening. So even after a major liver resection, the patient's IV is capped the same night. And next morning, there is no advancement of diet. It's regular food. So compared to our traditional program, the important changes have been using IV anesthetic. And in fact, by this strategy, about 40% of all these patients have no IV anesthetic during their entire hospitalization. So this can be done. So we instituted an educational program for our nurses by a one-sheet overall care plan for the patient, which used to be stuck on the front of the chart, both for minimally invasive liver resections and open approach liver resections. So when we audited our first about 135 patients, 43 have been on the traditional pathway, about 75 on the enhanced recovery pathway. You can see patients on the enhanced recovery pathway had a much better pain scores in the PACU in spite of receiving no or minimal narcotics. Patients on enhanced recovery pathway had about a 50% reduction in complications, and patients in enhanced recovery pathway had a decrease in length of stay. So when you particularly look at the length of stay, our traditional pathway length of stay for open liver resections was about 7 days. After instituting the enhanced recovery, length of stay has gone down to 4. For minimally invasive liver resections, our length of stay used to be about 3.4 days. It's gone down to 3 days. And in fact, one of our surgeons comments that patients on enhanced recovery with an open procedure look pretty much the same as a minimally accessed procedure in terms of their functional activity. So they were amazed at how well the patients do. And when we used this instrument called the MEDASI, which is MD Anderson Symptom Inventory, to evaluate their functional status, and when you plotted these scores from the preoperative phase to the post-discharge phase for both traditional care and the enhanced recovery, you can see it pretty much matches what Calet has been saying for 30 years. So in fact, by using these strategies, you can minimize that functional limitation immediately after surgery and get the patient back on track at an earlier phase. And when we looked at all the factors in a multivariate model and see which is the factor that contributed the most to return to baseline, it was patient on enhanced recovery. We also looked at the financial implications of this. So compared to the baseline, patients on enhanced recovery, whether they had a minor hepatectomy or they had an epidural or even a TAP-based enhanced recovery program, their pharmacy costs were down, their room and board costs were down, and the overall cost reduction was about 15%. We went beyond immediate complications, beyond pain scores, beyond opioid consumption, beyond length of stay. We also looked at a metric called return to intended oncologic therapy. As most of you would know, a patient with cancer, after having a resection, their quality of oncologic disease-free survival or progression-free survival improves if the patient has adjuvant therapies. So what we were trying to look is, with these protocols, can the patient come back to their adjuvant therapies after surgery at an earlier time? And if that is true, then the enhanced recovery truly adds value to the long-term benefits of the patient. So what we did was, at baseline, 87% of all our patients were coming back for adjuvant therapies at about 34 days. After we started enhanced recovery programs, this jumped to 95%. So 95% of all our patients were coming for adjuvant therapies, but they were coming almost 10 days earlier. So again, this is another indication that this truly can add value to the long-term outcomes. So with that baseline, what we are trying to do as a next step is to see if enhanced recovery improves return to intended oncologic therapies and thereby decrease recurrence and improve overall survival, at least in the cancer patient population. So we now have sent our initial findings of the effects of enhanced recovery on progression-free survival and overall survival on patients after major liver resection. This is still unpublished data. A publication is going to be coming down soon, but we found a significant impact of enhanced recovery in improving progression-free or overall survival after major open hepatectomies. So with that initial success, now we have 10 programs on enhanced recovery in pretty much every surgical service line at MD Anderson. We are also starting enhanced recovery using the same principles in stem cell transplant on the medical side of the house in medical oncology. Obviously, the patient needs and patient considerations for those having major cavity surgery is going to be different for those having stem cell transplant and who are on the medical oncology floors. But you can use the same principles, which is again putting the patient at the focus, minimizing symptom burden, and trying to see everything we can to enhance functional recovery. This is another set of unpublished data from our colleagues who are working on our bladder enhanced recovery program. And what they also looked is to see if what factors contributed to poor recovery in that patient population. And they defined poor recovery as a composite endpoint of length of stay greater than 7 days and readmission within 30 days. And length of stay greater than 7 days because this was one standard deviation from our median length of stay as a baseline. So if you define poor recovery with that definition, what they found was every one surgical complication increases poor risk recovery by 2.5-fold, which is not surprising, which is well known and logical and rational. But use of enhanced recovery decreased the risk for poor recovery 8-fold. This is, again, validates what we found in our liver program, and similar findings were seen even after thoracic surgery. So far, to date, starting from August of 2013, we did over 3,000 patients in various service lines, and pretty much consistently across the board, you would see about 50 to 60% reduction in total opioid use, about 30% improvement in pain scores, and about a 20% reduction in our overall length of stay. What we then did is to look at our NSQIP data. So NSQIP is a national surgical quality improvement program. It's run by the American College of Surgeons. It's a purely independent third-party collection of data, analysis, and events. And this is published and shared with all institutions across the country. Site 423 is MD Anderson, and this is our observed to expected length of stay across most of our surgical service lines. So if you see liver, which is hepatectomy, our bladder programs, and our thoracic surgery programs, our observed to expected length of stay is the lowest in the country. And these are the three areas where our enhanced recovery programs are most matured and most active. If you look at our average length of stay as an institution from the first quarter of 2011 to the second quarter of 2016, we dropped this as a whole by 2.5 days. Now, this is not entirely due to enhanced recovery, but because most of our surgeons have moved to minimal access surgery, but enhanced recovery is a big part of that. At the same time, we were tracking all our readmissions, and there's no change in the readmissions data. Similarly, compared to 2011, the mortality has come down significantly, and the morbidity of all cases has come down. So we were rated by NSQIP as one of the exemplary institutions in these different categories. So enhanced recovery works if done well. It's not a technique, it's a philosophy. I have to emphasize it's multidisciplinary, but with anesthesiologists playing a major role. I'm going to play a quick video of a patient experience. This is a patient who's had colorectal cancer. He's had metastases in the liver and the lung. So I'm going to show you the video of the procedure he's had with us with a low anterior resection, proctocolectomy, and anal anastomosis, 11-hour surgery. Patient went home on the third post-operative day. Now, it's our hope that every patient who comes to MD Anderson has the same experience, but it does not happen. Surgical complications drive patient's experience. So while everything I'm discussing today is in the setting of helping the surgeons provide better care, if we have a bad surgical complication, all this is out through the window. Can we play the video, please? Can we have the water? He had a proctocolectomy with coloanal anastomosis, low anterior resection with diverting ileostomy.
This is 10 minutes
and
in
intraoperative
recovery after
radiation
11-hour
therapy.
surgery.
Sam had received no narcotics intraoperatively. It was total intravenous anesthetic with an epidural. The anesthetic strategy which we designed at MD Anderson called the prompt technique. As I mentioned, we are 10 minutes after the end of the procedure. Okay, how are you feeling this morning?
Feel great. No pain. I started contacting folks, letting them know how I was coming along, and watched TV and just relaxed. I walked at about 10 o'clock. I want to estimate 8 laps. And I walked in a brisk
This was
fashion
first
also.
I
post-operative
see
day at
you
10
have
a.m.
a table full of some liquid breakfast.
Delicious hospital food. But other than that, the surgery was a complete success.
Okay. And your experience with pain control, nausea, sedation, mental clarity, all that doing well?
No nausea, none of the symptoms that would be expected.
Okay. Overall, you're very happy with your care so far?
Extremely.
Okay. And how do you feel right now?
Right now, I feel like a person that wasn't operated on last Monday. No pain. I've got good
This was
energy. I
Thursday
feel
morning
great.
at 10 a.m.
Good. And you're tolerating regular diet?
I'm starting to.
Okay. Good. And you had not required any intravenous pain medication during the whole hospitalization?
No, not at all.
Okay. Any other questions or comments you have that you want to share with the team here?
Just want to say thanks for a great job, people. You guys did excellent. It surpassed my expectations by numbers that I couldn't calculate. For just a procedure like this, it was incredible.
Thank you. And what we would also like you to do is give us your feedback on anything we can improve with the processes. We'd very much appreciate your input.
All right, I can't think of anything right now because that's why I'm here, for the best treatment there is in the world.
All right. Thank you, Sam.
Thank you.
So this was an amateur filmmaker trying to do a video with a real patient. So as I've said, that's our hope that most of our patients will have that experience. And again, I want to emphasize that this is indeed a teamwork. So when we set up all our enhanced recovery programs, we have an anesthesiologist and a surgeon as co-leads, and obviously this cannot happen without the help of our nursing team. A quick word about national narcotic epidemic, why this is becoming all the more relevant in today's world, at least in the US, is because there is this problem. Only yesterday in Washington Post, there was a big note which said every year there are 1.2 million people who get admitted to the hospital through an emergency care for narcotic overdose. So with our enhanced recovery strategies, we are able to limit the amount of narcotics that the patients are getting intra-op, but more importantly, how they're being discharged and how much narcotics they're having to be dispensed with. So 40% of all patients on liver enhanced recovery, 20% of all enhanced recovery GYN patients, 17% of all enhanced recovery patients on thoracic surgery received no IV opioids in the entire perioperative period, and 90% of all our patients on enhanced recovery in liver go home with no narcotics. So this true strategy works, but it's also relevant in today's care for enhanced recovery. And again, I want to emphasize that whatever reasons outside medical decisions influence patient care, why we are doing is for this reason. So with that, I want to again highlight that we are having an international meeting on from November 29th to December 3rd in Houston. We're going to be talking about perioperative care of the cancer patient, but also strategies we need to do to bend the acute care cost curve and improve perioperative and oncologic outcomes. Thank you very much.